Hello, my name is Dr. David Bartle and I'm a neonatal paediatrician in Exeter. I'm Training Programme Director for the ST4 to 8 trainees for the Peninsula, and I have been asked to present the key principle of the month, which is clinical reasoning skills are explicitly taught within training. What does clinical reasoning mean to me? Well, I couldn't find a fixed definition. However, my understanding of clinical reasoning describes the thinking and decision-making processes associated with clinical practice. It brings into play all parts of a consultation, including history, examination, and diagnostic tests. Reasoning is then used to work through all of the relevant and less relevant information, while at the same time being aware of confirmation bias, or the tendency to interpret new evidence as confirmation of one's existing beliefs or theories. The teaching is ideally done with real clinical cases, as opposed to artificially created cases, as real cases often reflect the false leads that one may have. This can be done on a ward round. For example, considering the different presentations of asthma on a ward round. Some are similar and some are slightly different. At the end of the ward round, the trainer has a reflective learning conversation with the learner to explore the patterns and signpost how the learner might build up their own internal library of patterns based on their existing knowledge and experience. It would be important for the trainer to signpost when a particular finding or pattern of findings almost guarantees a diagnosis. For example, the combination of short stature, webbed neck, and increased carrying angle in a female suggests Turner syndrome. Simulation-based teaching based around real cases is ideal for this, as there are set structures for debriefing based around a facilitated learning conversation. This enables the trainer to explore the learner's understanding and share the experiences of the wider learning team while being run in a safe learning environment. It is essential for trainers to acquire clinical reasoning skills in order to learn how to differentiate between relevant information and information that can be distracting. An example of this may occur on a neonatal unit. You have been informed that the oxygen requirement has increased on a preterm baby and have been asked to review this baby. Initial thoughts might be that the baby's lung disease has deteriorated. However, on further questioning, the baby has been having multiple apneas, which has led to the nursing team increasing the oxygen each time. The issue is not around lung pathology, but around respiratory drive. This is an important differentiation, as management might be different. Clinical reasoning is obviously essential for our day-to-day practice in order to train better clinicians and reduce inaccurate diagnosis. It is important to always consider, could this be something else? It can be a challenging skill to learn, and experience is helpful, but not essential. My teaching methods are based around my simulation experience and debrief structure, such as advocacy inquiry, along with facilitated learning conversations. It is important to lead the learner to the answer, but equally feed appropriate information so that they finish with a sense of success and can take this forward for future experiences. My experience of working abroad suggests that paediatric trainees trained under RCPCH guidance are regarded as having excellent clinical reasoning skills, so hopefully you're all in good hands.